right.
Hello, everyone. I'll give it just a minute for all of the attendings to make it into our session here. Okay, great. I think we'll go ahead and get started. Hello, everybody. Thank you so much for joining us today for Community Conversations hosted by UW-Medicine and the Office of Healthcare Equity. We have some of our experts here today to go over questions that you all have entered. Please feel free to use the Q&A if you'd like to ask a question during the session. Feel free to use that function. And I will go ahead and turn it over to Anita.
Hello, everyone. Good afternoon. Welcome to this edition of Community Conversations. It is an effort by UW-Medicine to connect with our patients and community in general and bring you closer to our experts. I'm Anita Chopra. I'm an internal medicine physician at UW-Medicine Neighborhood Clinic Shoreline. And I'm honored to have here an amazing panel with us. We have Dr. John Lynch, who is the Medical Director, Infection Prevention and Control at Harborview Medical Center. He's also the Associate Medical Director at Harborview. Dr. Lynch has been the voice of reason, science, and assurance for all of us at UW. We look forward to his weekly newsletters, which have been the go-to resource for all COVID-related information for us. Dr. Margaret Green is a Medical Director, UW-MC Northwest Wound Care and Hyperbaric Center. She is Chief Infectious Disease and Travel Medicine at UW Medical Center Northwest. We also have Dr. Shakita Bell, who will be joining us shortly. She's a pediatrician at Seattle Children's Hospital and the interim senior medical director at the Odessa Brown Children's Clinic. I also have with me Priscilla Estrada, who is the communications and workforce engagement specialist at UW-Medicine. Thank you all for joining us today, and for everyone in the audience, thank you for joining this session. We are focusing on the recently approved COVID vaccines for kids ages 5 to 11-year-old. We have gathered some questions from the community, and we will be asking our experts today. So Dr. Lynch, I'll start with you. Parents are very excited as well as nervous about getting their little ones vaccinated. Can you please tell us a little bit about the trial and approval of this vaccine? And in particular, is the sample size a concern at all?
Yeah, thanks for having me on, Anita, and thanks for the kind introduction. Yes, so as we all know that we now have approval for the Pfizer vaccine product for children ages 5 to 11. This was something that people have really been looking forward to over this whole last year since vaccines became available. Like all the other vaccine approvals for COVID and otherwise, these have gone through the same exact rigorous methodology in terms of doing studies in a group, which I'll talk about in a moment here. Then those data getting submitted to the FDA, and that committee doing an evaluation of all the data in a very rigorous format, making a decision, in this case, an approval from the FDA to move forward to the CDC for further evaluation. The CDC's committee, the Advisory Council on Immunization Practice, then reviews all of those data. It is good to recognize that in both cases at the FDA and on the COVID-19, excuse me, the CDC side, those individuals don't work for the FDA or the CDC. They're experts from around the country in various roles: immunology, virology, public health, and infectious diseases. Review all those data, and then the good news that as we learned about a couple weeks ago is that they also approved the FDA recommendations, and subsequently this vaccine product became available. You're right. This isn't the result of tens of thousands of vaccines given to this age group, but we do have to recognize that over 240 million vaccines for COVID-19 have been given in the United States. We have a huge amount of experience around these vaccines, And, you know, a lot of it had to be moved through in a very rapid fashion. I would say just very clearly that that doesn't mean that anything was skipped. All the steps were done, but just were done as quickly and as efficiently as possible. The same thing happened with the pediatric vaccination evaluation. So for this particular evaluation, they looked at one large study of about 2,300 children between ages 5 and 11, done this year. And it was what's called a randomized double-blind controlled study. So that means that they gave about 2/3 of the kids the vaccine, but they didn't tell them whether they got that vaccine or not. And they gave the other third of kids a placebo, in this case, a saline injection. So everyone in the study got a vaccine, got an injection, but they weren't told what was going to happen as a result. Just to sum up the impact of that is that when you look at what's called vaccine efficacy, I know you got a vaccine. I know you got the 2 doses of the vaccine, 21 days apart. It proved to be 90% efficacious. And this is very similar to the data that we saw in adults, including if you just want to narrow it down to sort of a younger cohort of 16 to 25-year-olds, looked pretty much the same, both in terms of reduction in infections and hospitalizations, but also looking at laboratory markers like antibodies. The antibody levels in 5 to 11-year-olds after vaccination was pretty much exactly the same as the antibody levels we saw in vaccinated adults between 16 and 25, right? So those really healthy adults. So really good news, very good data, and very similar to the other data that we used for vaccine approval in other age groups.
Thank you, Dr. Lynch. Dr. Green, is the Pfizer vaccine approved for the little kids the same as that for adults? Can you please tell us about the dose? Also,
that's right. It is the same vaccine, but it's 1/3 of the dose. So it's 0.2 milliliters is the volume of the injection, and 1/3 of the dose of the adult vaccine, but the same components, the same technology.
And the second part of the question is, are the vaccines for kids weight-based?
They are not. They are age-based. So kids who are ages 5 to 11 would get the pediatric dose, the orange cap vial. So that's one of the ways to keep them separate. And the adults and older kids would get the full dose.
Thank you. Dr. Lynch, what interactions can this vaccine have with other vaccines like the flu? Also, should we delay getting our kids other vaccines when we are giving them the COVID immunization?
Yeah, so we recognize that throughout the last 2 years of the COVID pandemic, one of the major negative impacts is the delay to routine pediatric vaccinations. So I would say right now it is more important than ever that if your kids aren't up to date on their vaccines, to get them up to date on their vaccine as soon as possible. Like adults, there's no contraindication to simultaneous administration of vaccines. We've done this now for months in adults, and that includes teenagers. And there's no reason to think that we would do anything differently in our younger cohorts. So the CDC originally came out with some guidance around separating things out, but that wasn't because necessarily like the flu vaccine was going to make the COVID vaccine not work, or the opposite. What the issue was is that with widespread administration of COVID vaccines, they wanted to make sure that if you got that COVID vaccine and then you had a sore arm, you had a fever, or had some other adverse event associated with it, that it was due to the COVID vaccine and not due to the flu vaccine or due to the combination. So it was really about learning about the vaccines. Now that we know about the rates of things like sore arms and other associated symptoms associated with the vaccines, the CDC's made it clear that giving vaccines simultaneously is totally safe and should be part and parcel of our normal pediatric visits.
Dr. Green, how do you make sure that kids do not accidentally get the adult dose? This is part A of the question.
That's a great question, especially as we're starting to vaccinate kids in environments that we're not usually vaccinating kids, like these larger vaccine clinics. But the CDC the FDA has actually made, it comes in a special vial. It's separate. So it's not like the nurses are pulling out a certain volume from one vial for adults and teenagers, and then they're supposed to know to pull out a certain other volume. These are completely packaged separately with different color coding to prevent that from happening.
And Dr. Green, can you talk a little bit about training that the nurses and the medical assistants get to actually give this vaccine versus the adult vaccines?
So it's really not very different from the other vaccine, except the vial will be a different one. So the, MAs and nursing staff and volunteer physicians like me sometimes give intramuscular vaccines all the time. And so the process of, reconstituting, mixing, everything is laid out and routinized and really a familiar skill to anyone who gives vaccines. And then usually in some of these vaccine clinics, they kind of pre-draw multiple vials so that they can make sure to do some quality checks and distribute pre-drawn vials for administration.
Can I just one other point or two other quick points on there?
Sure.
So I agree with everything Dr. Green just laid out. There are some of the clinics are doing sort of operational things, like you're an adult, you go over to those rooms. You're a kid, you go to those rooms, so that there's another sort of way to separate out the orange caps from the non-orange caps. I think it's gray or white caps. And so it also creates potentially just a more inviting environment for those youngsters out there. In addition, the CDC and others have put out lots of education for pediatric vaccinations for those who aren't typically used to it. And those have been used in providing updates to people like Dr. Green who are giving these injections. The other part of this is that, and I totally spaced on what I was going to say, but it was about separating folks out. Well, and
I think we will see an earlier move to giving these vaccines in primary care clinics.
Right.
So if the kids can get their vaccines in the environment where they're usually getting them. And I'm very happy to see that the Seattle Public Schools, for example, will be giving them in many of the elementary schools. So again, further separating it from adult vaccination.
I remember now. Also being able to give intramuscular injections into the thigh, which is more acceptable for some of the children in that age group, which is atypical in adults, but definitely allowed.
Okay, thank you. Dr. Lynch, this one is on natural immunity. I know many vaccinated people with breakthrough infections, but not many people who have had COVID with repeat infections. What do we know about the natural immunity and the durability of natural immunity after a COVID infection?
Yeah, this is a wonderful question. I would say that we still don't know the final answer on this. We have studies heading in both directions. And it all depends upon sort of what your most recent study you read is. I would say probably the most recent study that infectious disease doctors like Dr. Green and myself have just reviewed state that if you look at people who have had natural pre-existing immunity due to infection versus the natural immunity elicited by vaccines, that those who are vaccinated are at lower risk for developing disease due to COVID-19 compared to people who have had been infected, so infection-mediated immunity. We've also have pretty good data that vaccinated people appear to have less long COVID, this sort of syndrome where people get infected, even with minimal symptoms, but have persisting symptoms that last for months and months at a time. So I'd say the weight of the data right now is in favor of being vaccinated over the immune protection of natural or infection-mediated immunity. There are some studies out there maybe pointing in the other direction, but I would say it's just complicated. There's a lot of people out there who we don't know who have been infected. We also know for a fact that if you take a group of people who have been infected with COVID-19, that some of them are going to have really great, robust, long-lasting immune responses, and others are not going to have any response at all. And so that's part of the big problem with infection-mediated immunity. Is that it's heterogeneous, it's all over the place. And I can't predict how one person is going to react versus another, versus vaccination-mediated immunity, where the responses are much, much more uniform, right? We know exactly how much antigen, how much spike protein is going in there into a person that's going to then generate that level of immunity back. So I think that my take on this is that vaccination is definitely the way to go in terms of its predictability around prevention. Getting COVID is still very bad, even if you're a healthy person. We have young, healthy individuals, from babies on up who get very serious disease, who end up in the hospital, who end up having things like long COVID, who have critical care, and some of whom unfortunately die. And so looking at natural or infection-mediated immunity is probably not a healthy way to think about it. I also just want to address that first question, the first part of your question, which is that I know a lot of people, one of the major issues that, we're lucky where we live that most people are vaccinated. And when most people are vaccinated in the middle of a pandemic where there's lots of COVID being transmitted, most of the people who have infections are also vaccinated, right? So the Venn diagram overlaps almost entirely. If you lived in another part of the country or even the state where vaccination rates are very low, the vast majority of people with COVID are going to be unvaccinated. So it has to do with what the vaccination rates are in your group of friends and family and community. And I'll just let you know very clearly that when we look at who's in the hospital with COVID, it is unvaccinated people in the hospital, right? That's where unvaccinated infected people end up, unfortunately, way more than vaccinated folks.
Thank you. Welcome, Dr. Bell. I'm just going to direct the next question to you. My daughter is 11. Should she get the kids vaccine now or wait a few months and then get the 12+ dose? Also, what happens if a kid turns 12 after the first dose? Is their second dose higher then?
Great question. So yeah, thanks for having me. Sorry, I was a little late. I was seeing patients this morning giving COVID vaccines. Very exciting, but it keeps us very busy. So great question. First of all, I've been telling folks to go ahead and get vaccinated. I think when you can get it, you should get it. The reality is it's the same sort of parts of the vaccine. What's in the vaccine is the same. It's just a different amount. So if you think of the adult dose as being this big, the kid dose is this big. And what we've seen from giving kids the vaccine in the trials is that they're less likely to have side effects, that it's safe, and that it's very effective, really good at preventing COVID infections in children. So because of that, we are actually looking at whether we can lower the adult dose next year if we need a booster going forward. So it might be that kids are doing so great without side effects because they're getting that lower dose. But the bottom line is it's very effective, so there's no reason to wait until they're 12. The second part of that question is if you're 11 with your first dose and you're 12 with your second dose, which versions are you getting? For the first dose, you would get the 11-year-old, and for the second dose, you would get the 12 and over. So you would get the adult size dose. And there were kids in the trial who got that, and it was perfectly fine, perfectly safe, and still very effective. So there's no need to be concerned. Again, it's the same type of medicine. It's just a little bit different in the volume. Great question.
Thank you. And then Dr. Bell, I'll direct this question to you as well. It's in the chat. My concern is, why is the vaccine not weight-based? My concern is that the half dose won't be adequate for some of our taller kiddos within the 5 to 11-year-old range.
Yeah, so great question. They decided to do so the reason why it's not weight-based is the design of the trial. So Pfizer enrolled children across the country, and they decided to use age as a cutoff. So that was the decision-making of the investigators in the trial. It works for me in my mind as a pediatrician. I absolutely understand weight-based dosing, right? I do it all day, every day. That's why I have a calculator in my pocket because my brain is getting tired these days. But the reality is what it looks like, and I sort of suggested this earlier, it looks like that it's probably just as effective in adults, that amount of dose, and we might be moving in that direction in the future to lower it. And it also in the trials, they didn't see any difference in how well it worked or how much of immune response it built, regardless of weight. So weight didn't seem to determine it. they had to pick an age cutoff in order for the vaccine trial to be considered a trial. So they picked the age, but it doesn't appear that weight makes a big difference. And we're not seeing that in the results. We're seeing that regardless of how much you weigh, that the vaccine is effective and that it's safe. And it's probably the fact that it's probably true that moving forward, we may be getting lower doses as adults. And that's a little bit, I think John heard me say this last week, I don't try to predict the future in COVID. I think that's a fool's errand. But what I've heard of from the CDC and from folks who are working with the FDA is that they're looking at if they can lower the adult dose and maybe combine it with other respiratory viruses like influenza, so that we could get one respiratory vaccine every year. Again, this is all just like, you know, in the stages of being developed and studied and whatnot, but it does look like we could have the same efficacy with a lower amount in adults as well.
Thank you. Dr. Green, what if my kid only gets one dose of the vaccine? What percentage protection do they get from getting very sick?
So they will get some protection from the initial vaccine, but not the 90% probably efficacy. And the biggest difference is really the duration of that immune response. So your protection just won't be as long because you're not building up that memory response.
Dr. Bell, the next one is also for you. Can you please talk about the side effects of this vaccine? I hear that risks outweigh the benefit, but it means nothing to me. And this is from the community. Can you please talk about scientific facts and statistics from the trial about side effects?
Yeah, in fact, I can see if I can copy and paste some into the chat too, because I actually have a graph of the side effects. What we saw in children was that it was much less, that there were much less severe side effects and that was much less likely to experience side effects. Yeah, I'm not gonna try to do two things at a time. So I'm gonna answer your question, and then as we go to the next question, I'll try to put the actual data in the chat. But so we know that, for instance, if you think about what the risk of the infection is, like we know that the risks of COVID, the infection, are to be really sick, to be in the hospital, and to die. We know that the side effects from the vaccine are that you can have a sore arm, you can be tired, you can have fever. For adults, we've seen some vomiting, some diarrhea. When we look at kids, those rates are much lower. There is a piece of data that's showing a little bit of an increase in inflammation in the heart, something called myocarditis. It seems to be between the ages of 15 and 26. Everybody who has had that as a side effect of the vaccine has gotten better, has fully recovered. No one has died or had any permanent long-term side effects from the myocarditis or the inflammation in the heart. And what we have shown in the data of giving millions of people the vaccine around the world is that you're 30 times more likely to get myocarditis or inflammation of the heart from the COVID infection than you are for the vaccine itself. So if you can think about another good comparison for folks who work in medicine is with pregnancy, you have a risk of clots, and with birth control, you have a risk of clots. Well, it turns out with birth control, while you have a risk that's increased from not taking birth control, it's way, way less than getting pregnant. This is the same thing with COVID. You have a risk of this myocarditis, but it's much, much lower than it is if you get the actual infection itself. Again, that data looks like those are really more in the 15 to 26-year-old age range, and we haven't seen it in the younger kids. Albeit the vaccine trial only had 4,000 children in it. So overall, the serious risk factors for the COVID vaccine are pretty much non-existent. We haven't seen anything serious in children. And so that's the reason why I justify giving the vaccine, is because it's very safe. And in fact, even that sore arm, that headache, that fatigue is less likely in children. And for that reason, I strongly recommend the vaccine. I think we now have millions of people worth of data to show that it's really safe, it's really effective. And what we ultimately want to do is protect people or prevent people from getting the infection or from getting really sick with COVID.
Can I just throw one more bit of data there to Dr. Bell's comment, Anita?
Yes, sure.
Yeah, and I just want to remind folks that, I was looking at reviewing the slides that the CDC reviewed and the FDA reviewed in terms of their data, there have been nearly 2 million cases of COVID in children ages 5 to 11 since the beginning of the pandemic, and approaching 8,500 hospitalizations. So it's not a small number when we think about the impact of COVID on this population. And it's also important to recognize that I talked about some of the negative impacts of COVID. Obviously, it could put people in the hospital. There's this idea of long COVID. And Dr. Bell may speak to this later, but there's this other thing that happens, this multi-system inflammatory syndrome that happens in children. And that is most common in 5 to 11-year-olds, the group that we're really focused on today. And so, vaccines prevent a whole host of problems, ranging from medical illness to, loss of school time and transmission within families, and all of these other issues that are associated with COVID in a family or a group or a community.
I think that's very valuable. Thank you so much. As parents, we are, those are our bigger concerns.
What you're seeing on the screen here, sorry, I couldn't figure out a way to get it in the chat. So I was like, let me just share my screen. This is the data from the Pfizer trial for kids for 5 to 11. And you can see the comparison of in terms of side effects and in terms of how they rated their rates. And what we saw in adults was that the fatigue and headache were closer to 80%, and we're only seeing it in about 60% of kids. And even then, a lot of it was really classified as mild. So this is when I was mentioning how the side effects are less severe and are happening less often. This is the data from which that's coming.
This is great information. Thank you. Dr. Lynch, this question is about boosters. Will we need more boosters? Is there a chance that the virus will mutate to the extent that the vaccine will become ineffective?
Yeah, so the question about boosters, I think what we're learning from adults, and we don't know in kids, but it would sort of lend itself to that, is that boosters are probably likely in the future, right? We're seeing access to boosters for older adults, so those 65 and older, people with certain medical conditions, as well as, from 18 and up, as well as people in high-risk occupations. The data is really in the older adults, so greater than 65, where you see the most robust data around the benefits of boosters, and some data in that population of people between 18 and 65 with medical comorbidities. Dr. Green, Dr. Bell may have, opinions on this as well, but it's much less impactful in terms of those boosters for healthy adults, right? And so I think we're going to continue to learn about where we are with this. And we're only going to really understand as time progresses. I definitely ascribe to the Bell rule, right? Looking into a crystal ball is a mistake in thinking about what's going on. But the likelihood of something like an influenza-like program where there's annual vaccinations, annual influenza vaccinations, I wouldn't put it out of the realm of possibility, and probably closer to the realm of likely than not. But we're going to be learning a lot as we go forward.
Is there a concern about too many boosters? Could they get toxic?
No, this is actually a great question for Dr. Bell as well, as a pediatrician and an expert in this area. I have just to be clear, I have 2 children. Both of them are vaccinated against COVID-19. They're both vaccinated against influenza, and they're up to date on all of their vaccines. Vaccines, particularly in the pediatric population, are one of the most important decisions we make as a community, right? That's how we keep our kids safe. That's how we keep our community safe. It is probably the most important thing that adds to overall health in our communities. So I have no concern about multiple vaccinations, about the number of vaccinations we're giving to kids, or about the current schedule. But I'd really ask Dr. Bell to comment as well as an expert.
Yeah, I think some of the comments in the chat are getting to this. So it's a little bit about the way the mRNA vaccine works. So I think Dr. Green mentioned this. It's also about so it teaches our immune system how to build its own protection, and that memory will last a certain amount of time. And so what we're seeing from these studies, and just so you know, the vaccine trials don't stop as soon as the FDA gives an EUA. I'm in a vaccine trial myself, and I'm still in it. It's been over a year since I got the first vaccine. They're going to continue to watch me. We just made my appointment for next year. They're going to continue to watch what my antibodies do. And so what happens is our body gets exposed to the message, the virus or the vaccine, which tells us, hey, here's how you fight this particular infection. We make some special cells that know how to fight that infection. But what our research is showing, what the science is showing, is over time, our body starts to forget. So that what the booster is like, hey, poke, 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 don't forget, literally poke, poke, poke. I didn't mean that, but that was a good pun. Poke, 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 don't forget, we need to be able to protect ourselves against this virus. So your body knows how much protection to make for itself. It'll sometimes over time say, oh, that virus isn't, it's not really as important as whatever we're dealing with right now. So these boosters are really just reminders, but there's no such thing as getting too much in your body, because your body gets rid of the vaccine itself, and it's just holding on to the memory in terms of how to fight the infection.
Dr. Bell, do you want to take this one as well? When will the vaccine be approved for 2 to 5 year olds?
Yeah, that's a great question. So I'm gonna keep with the Bell theory. I'm not gonna give you a prediction. What I will tell you is that the studies are still enrolling in that age range, and right now it's actually 6 months and up. They do have a study here in Seattle. We are one of the Pfizer trial sites. So the 5 to 11-year-old data also some of it came from Seattle. They're still enrolling. So if you think back to like May was when they were enrolling those 5 to 11-year-olds, you can kind of get an idea at a little bit of the timeline. I would say it's not going to be any sooner than the spring. Probably, again, there's a lot of probablys, what ifs, maybes, just because it's so hard to know, but it's not in the near future. It certainly won't be before the end of the year.
Also, this has been a very commonly asked question. Why has Moderna not been approved for 12 plus kids? Is it the myocarditis data?
You know, I don't know all the answers to that. I'm certainly happy to pass the microphone to Dr. Green and Dr. Lynch. I will say that they did submit their data to the FDA a lot later than Pfizer, and they started their trials in that age range a lot later. So that is probably part of it. And then the other thing that I've heard personally from the FDA is that there isn't a strong drive to have multiple EUAs. So if we have a medicine that is safe and effective, there isn't, if you think about it like morally and ethically, why would we push to have another EUA when we already have a safe alternative that we know is working? So there's a little bit of that balance going on. Like, why not make sure that the vaccine trials complete with Moderna before just giving it full approval versus an EUA? So a little bit is the timing, a little bit is where they're at in their study. And then I don't know, Dr. Green or Dr. Lynch, if you've heard, I haven't heard that myocarditis has anything to do with the Moderna trial.
I haven't heard that either.
I haven't heard that either. And we have to remember that for all the vaccine products out there, including the ones we're using in the United States, there's an enormous need globally for access to these vaccines. And it's quite amazing the impact of the demand for the vaccines has had on lots of things. So all the glass vials, all the syringes, these have been like of a shortage across the planet. And so I think, as Dr. Bell mentioned, if we have a great product that's working safely and effectively in 5 to 11-year-olds, let's try to get those other products out to the rest of the world where they're desperately needed. You had asked a question about, am I worried about variants in the future? Again, I'm going to invoke the Bell rule here, but I don't know. The variant we're dealing with right now, Delta, which is pretty much 100% of all the infections we're seeing, seems to be in some ways fending off additional variants. So we're not seeing new things occur. But as long as we allow COVID-19 to run through particularly unvaccinated populations, small and large across the planet, the risk is going to continue. And we saw a whole host of these in 2020, from Alpha through wherever we are now, Mu. And I just hope it's not the same situation in 2022.
Dr. Green, if we get a choice between Moderna and Pfizer for our kids, which one should we choose?
Well, I have a kid who's under, under 12, and we're anxiously waiting his appointment to get his first vaccine. So I think for me, it's just whatever one they can get access to. If the Mrna gets approved for this age range, and that's the one that you can get to, then that's the one you should take. Similarly, and that's the same advice I've been giving to all of my adult patients. It's just take the one that you can get to, is really the best answer.
Dr. Lynch, the kids' vaccine contains an ingredient called tromethamine, which I understand helps to stabilize the vaccine. It is also used in metabolic acidosis. Can a child with kidney disease get it? Is there any information about the ingredients causing side effects?
Sure. So importantly, that ingredient, tromethamine, which is also known as a tris buffer, is actually in all the Pfizer products. It's not just the kid ones. It was actually reformulated so that we could have, the vaccines could have a more stable and longer lasting shelf life. It is commonly used. It's used in, I think, 4 or 5 other vaccines out there. And it just is a way to preserve the RNA, the stability of the vaccine itself. So and the amount in the vaccines is extremely tiny. Now, I think what happened was a combination of a couple of things. One is this drug is used, this chemical is used in people with, for instance, kidney failure, whose kidneys don't work, and as a result, their blood acid levels go up, and you can use this drug at much higher levels, like very high levels, in order to help control that. We're talking about logarithmically different levels of a treatment dose versus a level that's used in the vaccines, in the vial itself. And you got to remember, you look at what Dr. Green said about the absolute amount that goes into a person, an adult or a child. It's even a much smaller amount in that vial. So it's tiny little amounts. There is no impact on things like metabolic acidosis or these associated side effects of the treatment dose that we use in that with that chemical. So again, just a reminder, it's in all the Pfizer products now. It's a standard stabilizer to allow the vaccines to have a safer and longer duration of time they can be in the pharmacy shelves. So no concern from that at all. Unfortunately, it did make it kind of went through the misinformation sphere and kind of got amplified with only the medical treatment information and not the information in the vaccine itself. So I have no concerns about this component of the vaccine at all.
Dr. Bell, are there any plans to issue smart health cards in MyChart, like in Epic? Are there any plans to issue those cards for the kids?
I have been hearing some whisperings about that. I don't know where we're at in that process. And I don't know if Dr. Green or Dr. Lynch has heard anything more. I do know folks are working on it.
I've heard the same thing. I know within the UW Medicine version of Epic, you have to remember each of these places uses a different version of the same product, that their goal is to get there. I do not know what the timeline is. I think it's been used in other versions of Epic in other parts of the country effectively. And I hope we can get there as well. Just in case people aren't aware, right now there's 2 ways to get access to your vaccine record, including your kid's vaccine record. One is the myir.net, which you can look up and then you have to register. It takes a little bit of effort. It's been a little wonky in terms of the information. The other one is called Verify, Washington Verify. You can just Google it or go to the Public Health Insider. It's the Public Health Seattle King County website, and they'll have the link there. It's also in the Seattle Times, and that's a little bit easier. You just put your name, your birth date, and either the phone number or the email that you used when you registered. And it will give you, it's like immediate. It can brings up a QR code with your dates. And if you put your kid's name and birth dates and the right email and phone number, it'll give you those as well. And I've verified that with both of my kids. It worked when the MyIR didn't work, the WA Verify did work. And then you can just take a snapshot of it and it goes in your phone or similar.
Dr. Bell, is there any statistical information on post-vaccine antibody titers?
Not that's been released yet for kids. I think there has been stuff, John, you might know about the adult, where we're at with adult titers. I think that's in fact how they made the decision around booster recommendations. But we haven't seen anything published yet around titers. We've just seen the data around infectivity of COVID, so like likelihood of getting COVID during the vaccine trial.
Yeah, Dr. Bell's right. I mean, we only data we saw out of the FDA and CDC committees was that the antibody levels after vaccination were about the same as 16 to 25-year-olds antibody levels after vaccination, but it didn't tell us the absolute amount or anything like that.
And the next question actually is related to this. Dr. Lynch, maybe you can answer this. When do antibody titers rise fully after the vaccine?
Well, I think this goes back to what Dr. Green was mentioning, right? After one dose, we know that within a couple of weeks, the antibody levels do rise. And if you don't get a second dose, they probably hit a certain level. And then after some number of months, which we don't really know, it starts to decrease. One of the most important things about that is we don't know the absolute cutoff for that antibody level. So I don't know, you have, antibody level X that protects you, and versus antibody level Y, which may be lower. That second dose, we know, boosts further that absolute antibody level within several weeks of vaccination. And we know that the duration of that antibody level is much, much, much longer, on the order, of what we've seen so far is, for healthcare workers who have been vaccinated for a year, is still very high, and it's still extremely effective. And this goes back to your prior question around, are we all going to be looking at boosters? Well, if you look at healthy adults between 18 and 65, their antibody levels are still very high, and the vaccine, their rate of infection compared to unvaccinated individuals still is dramatically different, right? And so we know here in King County, the difference between a fully vaccinated versus a one dose or unvaccinated person is still around 10 to 12-fold difference, and even higher for hospitalizations and even higher for death. So the absolute number, we don't know what that means. We just know that the levels are high and continue to be very effective for, now a year plus out.
Dr. Green, my daughter takes Zyrtec every day for allergies. Will this interact with her vaccination at all?
Not at all. I assume that, common medications like Zyrtec and things like that have no effect on any of the childhood vaccines, and certainly reasonable to, again, get all of those vaccines that they need and can be all done together.
Thank you. And Dr. Bell, can you talk a little bit about the clinical trials for the vaccines? Did they have any kids who had the COVID-19 infection prior to receiving the vaccine? And did they react any differently? Or was their antibody titers reported, were they different from the regular population?
Yeah, great question. So they did not release data about the antibody titers, and they did not release information about individual patients. So remember, when you're in a vaccine trial, they actually want to try to keep it as anonymous as possible. One, to protect your confidentiality. I mean, I outed myself as a vaccine study participant, but that's my right to do. It's not another, like a company's right to say, hey, Shaquita's in the trial, go ask her if she had COVID before she enrolled. So they won't be able to say like how many, or specifically if Shaquita's in the trial, she had COVID, then here's her response. But they can give us a population level across the kids who were enrolled. And it, again, all of that becomes in part of that larger data set. So that's a really large way of saying it's not something that we could have picked out of the data. We don't see any evidence of that. It doesn't necessarily calculate to an individual level. With that said, we've now done millions of vaccines for kids 12 and over, and many of those folks have had COVID before they got the vaccines. And we have not seen any different response to the vaccine based on whether or not you have had COVID. So the CDC and the FDA have now said that it is perfectly okay to get the vaccine regardless of whether you have had COVID. The only caveat to that is if you have required antibody treatment or if you're on prolonged steroids for that COVID infection, then you need to have a conversation with your doctor about when you are recommended. And the CDC is recommending between 80 and 90 days after that treatment to get your vaccine. The other thing I always tell folks is please find your medical person, the person who you see, if it's a nurse practitioner, if it's a doctor, if it's a naturopath, have a conversation, say, hey, you know, I'm taking Zyrtec and I'm not sure, I don't know where to look for information on whether it's safe. I mean, we're happy to do that today, but I think it's also a great opportunity to have an educated conversation with your healthcare provider as well, especially if you're worried at all. But again, if you've had COVID, it's perfectly safe to be vaccinated. I've just told people to please finish their quarantine period before coming to the clinic for their vaccine, because I don't want to spread COVID, but otherwise it looks like it's perfectly safe to get the COVID vaccine after the infection.
So Dr. Bell, sorry.
I'm sorry, in adults, we don't have any delay. As soon as you're done with your isolation, you're eligible for, it's a 10-day isolation from the time of your symptom onset or your positive test. On day 11, you're eligible to get vaccinated. And it's the same thing for kids. And just confirming what Dr. Bell said, about 1 in 10 of the kids in the trial, that original Pfizer trial, had evidence of prior infection based on antibodies. So definitely, we're evaluated as part of this trial.
So this is really important for parents to know that right after the quarantine period ends, their kids are eligible to get the vaccine. Dr. Bell, were children with ASD, atrial septal defect, studied in the clinical trials?
I don't know, John, do you know if they released that level of data? I don't think they were that specific.
I cannot find the exclusion or inclusion criteria published yet, so I wasn't able.
I don't think we know. I've definitely given people the COVID vaccine who have had congenital heart disease. I've given personally through our clinic, we've given over 3,000 vaccines of COVID specifically. We do hundreds of other vaccines a day. And we have not had any problems. In fact, we have a lot of people sending their patients, adult clinics sending their kids to us because we're so experienced in giving childhood vaccines. I think I am less worried about the reactions to the vaccine than I am in terms of how to make the visit as comfortable and as safe and as educational for the patient to not cause trauma. I think that's more of what I've been focusing on, is how to help kids with social emotional delays get their vaccine, how to help kids with needle phobia get their vaccine. Those are a lot of the conversations we're having. And I think pediatric places or places that are used to taking care of kids are really good options for families who have children with special healthcare needs, because that's what we do every day, all day. And it's really, easy for us to get the bubble gun out or to turn on the iPad or to turn on the music and make it a really good experience for kids too.
One of the fun parts of last week is I went into the Harborview vaccine site on the first day they did that. And when I walked in, there was all these little kids in line with their families. And they were all just kind of jazzed to be there. And they had a special nursing station just for the pediatric vaccinations with little toys lined up, and they had puppies on the monitor playing with each other. And then one of the nurses had, don't talk about this, but logged into Netflix and had the cartoons up in the 15-minute waiting time on a big screen, and all the kids were just there. And it was just really exciting. The staff was, so enthusiastic, and kids were having a tough time. They did it and they were cheered on by the group, and it was just a really great thing to see happening. And I'm sure that's what happens at Dr. Bell's clinic every day, which is pretty cool. It's not like that.
We don't quite have the Netflix down yet, but we got everything else going.
Yeah, not Netflix, but a lot of Frozen too, right?
Yes, a lot of Frozen too, yes.
Yes. So Dr. Green, as a parent, how have you navigated discussions around the COVID vaccination, especially for the younger kids?
Yeah, so I actually have 2 kids in my family, and one is only 4. So she is, not eligible for vaccination yet. And then my son is 7 and is newly eligible. And we've been talking all along about how we talk about all of our vaccines, which is we get them to protect ourselves and we get them to protect our community and to be a part of that. And so they've already gotten their flu shots for the year. They kind of know the routine. And for me, this vaccine in particular is not that different. We are doing this to protect ourselves, to protect our community, and a little bit of a carrot to try to get back to some of those activities and some of that togetherness that they've really been missing out on these last few years.
The next question is about the accessibility to the vaccine. Dr. Bell, UW Medicine has made a lot of efforts to provide the, roll out the vaccine to the younger kids. Can you talk a little bit about how parents can, get the vaccine for their kids at UW Medicine sites?
Yeah, so first of all, I'm going to back up and get to a little bit of the crux of the question. The way that all of us have access to vaccine is how it is delivered and distributed from the state. So it's not that the UW was like, hey, we only want 300 vaccines, or, oh, we only, want to vaccinate our patients and not our staff. What happens is that on the state level, so the federal government is who's allocating or when approving the vaccine, and then the state meets. They have an ethics committee that says, okay, we need to make sure that this region is covered and this region is covered. Here's the population here. Here's special groups that are more at risk. And then they distribute the vaccine. None of us know. For instance, I order the vaccine for my clinic here. I don't know how much I'm going to get. I ordered 1,200. I got 300. That's just what they sent me. I open the box. I find out how much I get. So it really, I think the sign up process has been a little bit hard because we're all really relying on the distribution from the state, and we've only gotten the first supply so far. We don't know how much is going to come this week or next week. So we're all very cautious in promising something because we don't want to promise, hey, little Johnny, I'm looking at you, John, little Johnny can have his vaccine on Friday, and then we don't have any vaccine to give him. So that's why a lot of places are doing the wait list like UW. I think signing up where you can. The other thing I would really ask for people is just a little bit of patience. As we saw in the winter, we started off with a very limited supply for adults, and then over the course of the first 6 weeks, we started to have lots and lots of vaccine available. And this is the same thing is going to happen with the 5 to 11-year-olds. We are starting with a limited supply, but eventually we will have absolutely enough vaccine to vaccinate every single kid. So I would start again with calling wherever you receive healthcare, calling them and asking them if they have the vaccine available and how they can get access to it. If they don't have that vaccine available, if they're partnering with anyone or if they have recommendations to get it. And then just a little dose of patience. I promise it is going to open wide up and all of our kids are going to be vaccinated or be able to be vaccinated.
And then, Dr. Bell, holidays are coming up, and some kids will get their first shot, and there will be a delay until their second one. How long can they go if they are traveling, say out of the country? How long can they go before they get their second one?
So the COVID vaccine trials, what the CDC is recommending is you get that second dose between 21 to 24 days-ish. That's the recommended time. We cannot do the second vaccine sooner, but we can certainly do it a few days later. Things happen, right? I had somebody get their first dose and then have an appendicitis the day before their second dose. And, we're going to put that off for 2 weeks until that person's feeling all the way better, off their antibiotics, and totally feeling great. Then we did their second dose. It's totally okay to delay it if we need to delay it. I will say just a word of caution though, is to remember that when you get a first dose vaccine, you are not fully covered. So if you are planning travel, if you're planning a holiday get together, you should calculate that into the risk. So one of the things people ask me is, if my kid gets their first dose, does that mean we can fly and see our family? And, I think the answer is it depends. How long is the flight? Where are you going? What are the COVID rates there? Are the people you're visiting vaccinated? That versus getting in a car and driving down to Portland to visit your vaccinated parents, that seems really super safe to me, especially with a kid who's had one dose. But getting on an airplane and flying to the parts of the country where COVID is still really going strong, I think sounds like it would still be really dangerous and something for you to consider in your calculations of your holiday plans. The other thing I think that's a little bit hard, and I'm hearing, and I don't know if other people are hearing this, is, hey, I really want to get my kid vaccinated this week so they'll be fully vaccinated for our Hawaii trip over Christmas. And my first question is, well, when did you book those tickets? Because none of us knew when the vaccines are going to be approved. you know, I want people to make sure that they're making these decisions in a really educated way. I think we're having these very serious conversations because this is a big change. The pandemic has been a really big new experience for all of us. And this is not just about one person or one family's vacation plans. This is about our human population on a globe. And so when we're making these decisions, when we're trying to decide how to keep our kids safe, I want folks to just remember to think about that. And I know we're all anxious to get back to normal life, but it's going to still take some time. Even with starting 5 to 11-year-old vaccines, there's hope. It's great, but we still need to be really cautious and really aware of how our behaviors will impact other people.
The next question is, Dr. Green, when my kids are fully vaccinated, can I relax a little about masking?
Well, I think it really will depend on where our community is with transmission, you know, at the time that happens, on what, you know, the risk levels are, you know, what kinds of activities, where you're doing this masking. All of these things kind of play into everyone's role. I know that we sort of had to backtrack when adults were able to get fully vaccinated. And then a lot of places said, okay, if you're vaccinated, you can be unmasked. And then boom, Delta was surging right, you know, or beginning to come up right at that point. So it really depends on where we are in our community, and also your kind of individual risk tolerance. For some families, if they have a high risk person, I think they need to continue to mask for some period of time in higher risk, in places where you're at higher risk of getting exposed.
Dr. Lynch, the next question is a general question about the coming up holidays and travel. And people would like to know your opinion on whether they can gather indoors safely, whether they can gather indoors with grandparents who are unvaccinated. How about masking, and how about travel? What would be your recommendations?
I think this is an individualized risk assessment, right? It's based on lots of things. It's based on your risk tolerance for your family and the risk tolerance of those who you're around. I'll just tell you my approach to this. So for instance, for Thanksgiving, we are likely, my family, I'm married, I have a partner, I have 2 children, all of us are vaccinated. We will be having Thanksgiving dinner with another family who we've had Thanksgiving dinner with last year during the pandemic, who we spent a lot of time with. All of them are vaccinated as well, and their parents. So 2 sets of in-laws, all of them are vaccinated. That's it. That's what we're doing. I am not traveling for any other holiday this year. I am not going to see my extended family in Kentucky or in Rhode Island for any other holiday. I'm really staying local, and that's where I'm sort of drawing my line. In terms of, I think a lot of people have been asking about like grandparents traveling. If you're indoors and someone's not vaccinated, you got to be wearing a mask. And I know we're really focused on pediatric vaccination here, and that's obviously super important. COVID is going to find people who are in mixed indoor settings where people are unmasked. And that can happen in small settings. It can happen in large settings. And you never know what's going to happen when someone gets COVID. I'll just say that. Yes, the younger you are, probably the less likely to have a very serious outcome. The much older you are, the much more likely you have a very serious outcome. But serious outcomes are seen across the board, from Seattle Children's Hospital to Harborview in Northwest. And so my take on this is fairly safety oriented and conservative. And I'm an infectious disease doctor. My wife's a nurse. When I talk to my infectious disease colleagues, we all feel pretty similarly. I don't want to speak for Dr. Green or Dr. Bell, but I'm being careful. The future, I think, is bright with vaccination, particularly for 5 to 11-year-olds, right? That's going to be huge for all of us as a population. But we still have a ways to get there. So not sure I answered your question, but that's the best I can do.
Thank you. Thank you very much. Thank you. And with that, we come to the end of this session. Thank you so much to our panelists, Dr. Lynch, Dr. Green, and Dr. Bell. This was an amazing session, very informative for parents and families. And as a physician and as a mom, I'm so thankful to all of you for the valuable input. And our next session is the community conversations with Dr. Vin Gupta. I think that would be an amazing session for all of you as well. It's on November 17th at 6:30 in the evening. We wanted to keep it late in the evening so parents can attend. Thank you so very much, everyone, for attending today. Thank you.
Thank you.